the content of today's discussion. This was a sort of an ad hoc presentation that was planned based on some of the things from prior echo groups where providers had asked for resources or some information on how they can manage their self-care, and particularly with working with the populations that we work with, that can really be a challenge. And so that's the focus of today, is to identify both what can individuals do and what can a system do to prevent, mitigate, and manage the issues related to working with the traumatized population, such as burnout and compassion fatigue. I'm going to go through and identify those different terms because we tend to use them sort of all as one. So it can be helpful to really understand that what they're talking about with burnout, compassion fatigue, and secondary traumatization are levels of intensity on a continuum of things that can happen to providers, and then also identify a phenomenon that's actually a positive aspect of working with traumatized populations, which is post-traumatic growth. So talk about what that is and define that terminology. And then the majority of today is really going to be focused on what are some evidence-supported self-care activities, techniques, perspectives that providers can apply to help them navigate their risk or their vulnerability to these issues. So starting out, painting a picture on what sets us up as providers working with a traumatized population. Obviously, these folks are coming in with tremendous stress. And so that places the providers that work with them at risk for things like vicarious trauma, secondary traumatic stress, and compassion fatigue. Here in Bernalillo County in Albuquerque, we are consistently ranked one of the top 10 most dangerous cities in the US. We have lots of issues related to violent crime within our community. And then as a state, New Mexico is ranked one of the highest in youth trauma exposure. So at the national level, about 1 in 10 children, so 10%, have experienced 3 or more what's considered adverse childhood events. And so there's a tool, there's a metric called the ACE that rates those adverse events, which are the majority of them are a true trauma. And you can see the percentage of folks, 25% will experience at least one. So these are really high rates. I wanted to show you, when we're looking specifically at a subset of the population that we likely end up working with substance use disorder, they tend to be criminally involved or have had criminal involvement at some point. And so our youth that experience any kind of criminal involvement, so the New Mexico juvenile justice facilities, their ACE scores are through the roof. So that's in that 86% falling at 4 or more ACE events over the course of their life, which is pretty significant, right? So what does that mean? Well, that means that the people that we're working with, adolescents, adults, throughout the developmental continuum, are gonna likely have very high rates of severe mental illness and really severe substance use disorders that are associated with trauma exposure, or at a minimum, what would be considered toxic chronic stress. So the difficulties with sort of all of those social determinants of health, major barriers to accessing the types of resources and social supports that are needed to offset those level, the level of chronic ongoing stress. So what does that result in? Well, that's gonna have implications for the level of physical health and wellness that we see, and the types of complexity of physical conditions. It's going to have impacts for, like I said, the likelihood of being involved or have experienced some level of incarceration or criminal involvement, sort of in and out of that system, and then what that does to a person psychologically. So if that's the population that we're working with, we're also, as providers, getting exposed to a lot of that toxic stress and trauma symptomatology that's coming into the room and impacting the interactions that we're having with those folks, and even just the stories that we're hearing. And so that puts us as providers at risk for one, if not all three of these conditions: burnout, secondary traumatization, and vicarious trauma. So what does that mean? So starting on the left-hand side and working to the right in these columns is describing the differences between these conditions. And you can see that there's a lot of similarity, but as we go towards vicarious trauma, we get into more and more severity in terms of the outcome for the provider. So the first level of concern is provider burnout. And that tends to look like, at least outwardly, sort of a general dissatisfaction with their job, with the population that they're working with. And this isn't exclusive to just working with traumatized populations. Burnout can happen in any profession when there aren't enough systems level, individual level supports to help that person. But it tends to come with symptoms such as exhaustion or fatigue, just feeling like I can't get my energy up. I'm just not motivated to get out of bed. Really a loss of motivation in general, not interested in learning more about how to help that population, or I just can't read another paper on it. I just can't think about it. And the hallmark is a lot of cynicism. So this sense that doesn't matter what I do, nothing I do is really going to make an improvement. These people have always been sick, are always going to stay sick. I'm just another cog in the machine. Like that kind of cynicism is really the hallmark of you're getting close to burnout, if not already kind of in the throes of burnout. Also start to have an impact to how you're working. So difficulty managing workload, lots of sick time or needing to call out. And that results in sort of feeling like I'm not performing up to my usual level of performance, or how I maybe have performed in the past, feeling a sense that I'm just not accomplishing the things that I want to accomplish. I can't get caught up. I can't get on top of it. And at that level, when we're really looking at that exhaustion, cynicism, general job dissatisfaction, the recommendation to intervene for the provider is to hopefully catch it early, say this is starting to happen, and to take time away, to prioritize vacation, and to make what changes can be made to the work schedule, to the work tasks, to say, there's either too much burden on me that is the system is not supporting the structure that I need to offset or manage the burnout, or I'm not taking enough of the personal supports, taking access of the personal supports that I need. So if you've got a ton of accrued vacation days and you're just not using them, that usually is kind of a red flag, a risk factor there. Secondary trauma is where we've now moved up into a little more intensity in symptomatology. And this comes when we work with a traumatized population and is usually specifically related to a close relationship to one particular patient whose story is really impactful, whose symptoms are really impactful. And we fall into a position where our symptoms, our difficulties in life and work actually start to mirror our patient's experience. So, for example, if you're working with a patient that you have really good rapport with, you feel very, very connected to, and they have a lot of social anxiety, social avoidance because of their trauma. They feel really unsafe at the grocery store or stopping to get gas. And you start to notice that in yourself. You start to notice sort of increased vigilance, increased anxiety when you're in those settings. Your symptoms are starting to mirror the individuals. It tends to happen pretty quickly in working with that patient. You start to recognize, oh, this is maybe some secondary trauma that's coming online. It can be unpredictable. You could be a provider who's worked for quite some time and have not experienced this and it just shows up. Or it could be that you're a relatively new provider. It's one of the first patients. So it's kind of unpredictable, but it does have a specific trigger of there's something in that patient's life story or their trauma history that's personally triggering this stuff with you. And why that's happening is because you're a good provider and you're having empathic connection. You're relating to their life experience. You're personalizing it sort of unconsciously to yourself. And that empathy is in and of itself a really good thing and an important part of doing effective work. But sometimes that boundary can get crossed unexpectedly. And before we know it, we are feeling a lot of the same things that our patient is feeling: out of control, feeling sort of powerless, lots of anxiety. And that can translate to feeling I'm not doing a good job. I'm not able to help this person. And so at that point, when secondary trauma starts to come online, the recommended intervention is to really look at our self-care routine and bump that up. Because that's usually a sign that should be a warning sign. Oh, I'm vulnerable. Either I'm not taking care of myself the way I normally do, or maybe the way I need to work with this particular patient. So I need to really dramatically increase that therapeutic self-care. At the next level, as we bump up into intensity, is what would be labeled as vicarious trauma. And that's very similar to secondary trauma, but it's related to working with a group of patients that have similarities. So you're not empathizing with just one patient. You're actually having this mirroring of symptoms to multiple patients. So those symptoms tend to be cumulative and maybe a little more uniquely related to your personal history, and they will start to impact both work and home. It will start to impact how you are in your personal world and your social circles. And this is the risk for providers who have worked with a traumatized population for a longer period of time and have not had in place the type of either the amount or the effectiveness regarding their self-care, regarding their both personal supports and the system level supports, so that accumulation of secondary trauma symptoms is sort of increasing and now becoming a chronic problem for the provider. Again, it's related to empathizing with the people that you work with, but it starts to really be corrosive for the provider's ability to work effectively with that population and also to be effective outside of work in their personal life. So again, a lot of that feeling out of control, powerless, but now we're adding in things like, I just feel overwhelmed. I just can't face it. I don't know how to help these individuals, lots of hopelessness. And it can start to transition into a mental health condition in and of itself. So some emerging depression and anxiety condition that's going to have sort of more long-standing impact and is very much going to impact work. So the remedy for vicarious trauma, once a provider's gotten to that level, is not just increased self-care, but now we really need to have a bump up in self-care, time away from work, and likely the same types of treatments that we would recommend to our patients. So seeing a therapist ourselves or getting our own mental health help to bolster those internal internal supports, and also reaching out to administration, reaching out to our supervisors and our peers and colleagues to say we need to look at this from a systems level, right? That there's I am getting exposed to so much of this vicarious trauma as part of my role. Let's talk about, can we build in breaks? Can we alternate how we see these patients? Can the level of intensity of that interaction be dialed up or dialed down depending on the schedule for that provider? So also having some systems level supports to manage vicarious trauma. So I'm going to go through a couple different levels and just focus on that last line. What do we do about this stuff when it starts to come on, and look at it both from an organizational level and a professional and a personal level, because it isn't just about the person and their self-care. It's also about how that system is functioning and how that system is protecting and supporting its providers. So one of the first things to prevent that whole slew, burnout through vicarious trauma, is training and making sure that we have really clear training on trauma and trauma-informed care, that everybody on staff, from the people that check in, all the way to the providers, are very well versed on the symptoms of trauma, not just PTSD, not just the interventions, but what does this look like, and how does this affect the patients that we're dealing with? And then how do I provide trauma-informed care? What does that look like from the multiple levels? Making sure that we have in place some level of clinical supervision. That could be peer supervision or peer consultation, things like this, like ECHO, coming and discussing cases where you just have a safe space where you can come and brainstorm, get assistance, relieve some of that pressure off of the boiling pot that's going on any given day, to get some of that extra support. So if your system doesn't have in place protected time for this, that's a risk factor for provider burnout and secondary trauma. So making sure that there's some space for clinical supervision and consultation, and that there's also organizational support for staff development, continuing education, and the really access to the types of tools that are going to support a provider in working effectively with that patient population. Because one of the biggest risks that starts this ball rolling starts at the burnout level with not feeling effective. And so if I don't have access to effective interventions and effective tools, that's going to really put me at risk for burnout, which kind of starts this process. Also making sure that from an organizational level, there's vehicles for the leadership of that organization to communicate effectively with the staff level, to make sure that staff feel the same things that we want our patients to feel, that they have some control over how the system functions, and that they have the ability to provide input and feedback, so that when decisions get made or changes get made or modifications are needed, that they feel like they have some autonomy and some power in those decisions and those changes. So making sure that there's a vehicle for that bi-directional communication. And then along with the education on trauma-informed care, having a trauma-sensitive physical environment and workspace. And so that's looking at how do we have things set up in our physical environment? What are the things that are necessary to make sure that not just patients feel safe and supported, and like this is a confidential space for them, and a physically safe space for them, but the providers feel that as well, that they have those same things in place. So in terms of you guys and your experience, and feel free to chat in or unmute yourself, but just real quick, what do you think are some of the signs that you're starting to run low on compassion? Like what shows up for you that like, oh, this is, I'm kind of entering into that risky zone? Is another concern that shows up. So in addition to burnout, compassion fatigue is something that happens as a result of empathy, and something that is where we're sort of moving from that burnout into a serious issue where we really need to address it. And a lot of the symptoms that you guys described, so avoidance or dread of working with certain patients or even just going to work at all, a reduced ability to feel empathy towards the people we work with, starting to use sick days or mental health days a lot more frequently, that lack of joy or enthusiasm or excitement about your work, just, oh, here we go again, here's another day, and that cynicism. So if you think about this is sort of the light that comes on in your car when you're getting low, when you're approaching the empty on your gas tank, that you're really not satisfied with work anymore, and just have no more gas to get you through. Now I'm entering into compassion fatigue, which is going to set me up for serious burnout. So what are these emotional symptoms? A lot of things that you guys were talking about. So kind of that low patience or that irritability, anger. It can also show up as increased anxiety or just feeling kind of like I had a little too much coffee today and that just never really goes away, or sort of restlessness. I just sort of don't know what to do with myself. Oversensitivity. So if you find that you're snapping at people, or you're taking things really personally, it could also result in, hey, I'm normally would only have 1 glass of wine a week, and now I'm having 3 or 4 glasses of wine a week. So an increase in relying on substances, sort of a issue cognitively. It can almost start to cloud. God, I can't remember that. Or things used to come so quickly to me. And now that tip of the tongue stuff is happening on an almost daily basis, really difficult concentration or focus issues. And when you start noticing that you're not maybe making the clearest judgment calls, and part of you is kind of not invested in it, like, oh, well, on to the next. And then you have physical symptoms that can show up, like increased headaches, having all kinds of GI problems, muscle tension. Sleep disturbance is one that's really common for people, either a difficulty falling asleep or staying asleep, or on the opposite end, you're sleeping way too much. You normally sleep 8 hours. Now you're tending to be up on the 10, 11 hour time. And that sense of fatigue that never goes away, no matter how much sleep you're getting. And then because it's sort of, I think of this as really a sign that you're under tremendous stress that isn't remitting. You can have cardiac symptoms, so that heart palpitations or tachycardia that's showing up with no underlying physical contributor. So what are some of the vulnerabilities that set us up as providers to develop compassion fatigue, and then later some of these other issues, burnout, vicarious trauma? Believing that your actions will not make a difference or don't seem to be enough. So that's called low compassion satisfaction. That means that you're not getting enough input from your output. You're not getting the gas back that you're giving. And that's a real problem when we work with a traumatized population, a substance use population, because these folks, this is a chronic condition that they're not likely to get a whole lot better right away. And so it's this long marathon that you're on with the people that you're treating. And you can run out of gas before you start to actually get any of that stuff back. And so that cognitive shift of nothing I do matters, it doesn't ever seem to be enough, these people are never going to get any better no matter what I do, that's a real vulnerability that is potentially contributing to that compassion fatigue. And then this is the main one, and I don't think we spend enough time really focusing on this, because we talk a lot about what individuals should be doing better or more of to manage their risk. But when your system is stressed and your system is disorganized, and we all care about the patients, or we wouldn't be doing this job, but sometimes we have too many patients because the demand is unending, that the patients that we have on our caseload, maybe the caseload amount is manageable, but every single one of them are horrible trauma histories and severe mental illness and severe substance use and high acuity. And so we're really like one little slice of their whole really complicated, very acute picture. And in that feeling of I can't do enough, it makes perfect sense, right? So looking at this, what is my system doing to set me up to experience this? Having to put in overtime when we're down staff and we have to take up the slack, having to do extra days when you really needed that weekend, or you really needed that day off, but you got called in because so-and-so quit, or there was no one else to see that patient. And then when your leadership doesn't have enough resources or enough information about trauma-informed care and what's necessary to support providers. So I hope one of the take-homes from today is that you all can go back to your administrators, to your leadership, or if you are a leader, to think about what can we do differently as a system to support our providers, because a lot of times it's not just about the individual doing more, it's about what does the system need to shift to support more effectively, right? Another vulnerability is if, of course, just like with our patients, every little additional stressor is going to increase the burden on that system. That's the same thing for us. So if we have stuff going on that's personal outside the workplace, and we're human and we will, then we're going to have a lower gas tank when we show up, right? So those resources are going to be a little more stressed. And then if we over-identify with patients, or we overlook serious symptoms that are going to impact our patient care, both of those things can make us more vulnerable. So how do we prevent this? First, we have to recognize what the symptoms of compassion fatigue are. So coming to a lecture like this is a great start, saying, oh, I actually relate to some of this. I might be in a vulnerable position. So that's number one. I got to acknowledge that there's something going on here, and then learn how to ask for help. I think we really do need to support each other as a community, and not shame this and not view it as a personal weakness if a provider is struggling with compassion fatigue, because like I said, a lot of it tends to come from the system not having the resources or the supports in place, and the fact that the community that we're working with is highly, highly traumatized. So compassion fatigue is going to happen to a lot of us on some level. So we need to be able to talk about it, and we need to be able to ask for help when it's there. And that can make a big difference. Even just a one-on-one conversation with a peer, I'm really struggling right now, and having them go, yeah, me too. Let's just share that experience. That can make a real big difference. So don't be afraid to talk about it. Don't be afraid to ask for help, and accept that there are going to be limitations on your job and yourself. And when can you say no? When can you sort of say, you know what, I would love to give that talk, or I would love to be able to provide that training, or I would love to go do this extra thing, but I really just need to take that day, or I'm just not in a place right now that I can do that. So it's okay to say no. And then understanding that this is part of the work that you do, the intensity of the work that you do, and it is not a personal weakness or reflection on you as an individual or you as a professional. So reminding yourself, and sometimes it's as simple as putting a Post-it note on your computer, you make a difference. If you made one small shift for one person today, that's monumental. Like, so doing something that is an inspirational cognitive shift, that what you do matters, and saying that to yourself. And because once we start to forget it, that's when sort of that snowball begins to really pick up speed. Another area that we can focus on is take action where you can take action. So trying to keep on top of daily responsibilities and duties. Before you add a new responsibility to your plate, ask yourself, am I caught up on my documentation? Have I gotten everything off that to-do list? Because if not, it could start to be that overwhelming, unmanageable sort of schedule or list of tasks. And then making sure that you're taking time out every single day, even if it's only 15 minutes, to renew and recharge. Does that look like I'm going for a walk, or having a phone call with a loved one, or going to get coffee with a colleague and just chatting about nothing, right? So taking that time out every single day, that's just a few minutes, is really, really important, that we're not just going from patient to patient or task to task. And then organizing things so that you can concentrate on what's truly important, and letting the other stuff slide a little bit. That being perfectionistic isn't going to help us when we're sort of dealing with the amount of difficulty that we're dealing with, and being able to distinguish what's truly stressful and what's part of my personal life that I need to attend to, versus what's truly a stressful aspect of my job. So for you guys, in terms of burnout, so once we've identified, okay, we have some compassion fatigue risks, burnout, sort of that next phase that we begin to enter into, what do you think are some of the biggest contributors for you in your work? And again, just a minute, chat in or unmute yourself. A little bit more here in a second about things that the system can do, that you can do to try to manage burnout. But one of the things that I want to shift into is this concept called post-traumatic growth, because if we can work and move through our compassion fatigue and our burnout, and get back to a place where we do feel like what we do matters, even if it is that one small thing, even if it is just I put a smile on that person's face today. They came to their session today, right? Like that is a big deal. Then we can start to focus on what our patients get when they enter into recovery, which is post-traumatic growth. So I love this quote: "The world breaks everyone, and afterwards many are strong at the broken places." And that's so true for people who've experienced trauma. Once they get on the recovery side of it, then they recognize they are better and more capable to manage those stressors and those strains than they were prior. And that can happen for us too, right? That through that process, working with these folks and helping them and focusing on those small shifts in improvement, that we also build our resiliency. We build our ability to say, you know what, even though I have all these barriers and I don't have these supports in place, I'm still showing up every day, and I'm doing what I need to do to help the folks in that particular moment, right? And that is an amazing thing. So recognizing that you have tremendous personal strength, that the effort that you're putting into helping them is also helping you, and that you will continue to move through that if you can hold on to the fact that you do matter, and also at the same time work to improve your coping strategies, your supports in your life, even if the system isn't going to support that. And highlighting that there are other important things in life, right? That there needs to be time off. There needs to be time for you as a person to flourish and feel like you're more than just your job, or you're more than just going through the motions. So we can actually have this as therapists or providers working with this population and move through that process very similarly to how patients do. We can change our schema about the world to more positive view through making some of those small psychological shifts. And some of that comes, with really recognizing, man, the folks that I work with are survivors. These people are not made out of glass, that they have overcome odds unlike anyone I've ever seen, and they're still here today. They are alive today, right? And so that can help hold on to that big picture of what's necessary to achieve that post-traumatic growth. So really understanding, they taught me more about, in the midst of all this trauma and suffering and uncertainty, of remaining true to who you are and what love can be about in those moments. So really focusing on the here and now, what is happening right in front of me, even if it's a small shift or a small exchange, and it's not that overall they've made every gain, they've achieved every goal, they're totally abstinent, right? But they're here today, they're interacting with me today, and I had some place in that. So in terms of what can we do, multiple people acknowledged, and that's really important, the factors that influence this that have to do with the system. And this actually comes from the National Academy of Medicine, which is a really nice graph and shows you, okay, what is related to burnout and compassion fatigue? Well, one is the patient well-being, the clinician-patient relationship, and then the clinician well-being. So what do I do as an individual? But this whole umbrella, everything that's on the outside, are systems levels thing, right? So the personal factors and the skills and abilities of the provider are really only two slices of the whole pie. We're looking at the culture, the community in which the treatment is being provided, the rules and regulations of the system, the organizational factors, the practice environment, and then the responsibilities, like where I was saying, like when there's so many things placed on you, you're only one person. You can only do so much. And so that this study was really important, just showing, yes, we want to focus on self-care, but that's only one slice. We have to look at all of these other things, and we have to work together as a community to take a systems level approach to professional well-being. And so what would that look like? Sharing with your leadership, having really intentional conversations with your leadership about, how do we create a positive work environment? What would that entail? Does that need team building activities? Do we need to have space during the day to just have lunch with each other? Like, how do we create that positive work environment? How do we advocate as a team not just me as a solo, but as a whole team, this is going to affect change for everybody and trickle down to address the issues with our patients more effectively. And talking about burnout, even at the training level, right? So starting talking about this is something that's going to happen to all of us eventually. So we need to prepare for it in advance. We need to actively be thinking about it and having these conversations regularly as part of the work that we're doing. And one of the things that can really impact and address that is making sure that we have trauma-informed care policy and procedure, and that our leadership supports that education and supports that within their policy development. And if not, what do we need to do to advocate for that and to push for that? We also need to talk about how we can reduce tasks like at the administrative burden. How can we divide and conquer more effectively so that, yeah, we can all wear multiple hats, but really let's get everybody working at the top of their license as quickly and as frequently as possible. And a big part of that is also having conversations about increasing the usability or relevance of IT. There's a lot of technologies out there that can really help us work smarter rather than more. And having those conversations, where could we have that technology, or how can we capitalize on that technology when it's present? And then have those regular conversations about burnout recovery to reduce stigma, that this isn't a personal shame, that this is something we all experience at some point in time. So it really should be a national research agenda. It should be a major part of clinical training. It should be a big focus that we're addressing as a community, to say this happens to us. And so what are we going to do about it? So now let's shift into individual stuff. One of the ways that you can address where you're falling, if you haven't already kind of sorted that out, is taking a measure called the ProQual-5. And I always recommend that providers do this fairly frequently, at least once a year, if not a couple times a year. It's a self-assessment where you ask yourself questions about your compassion satisfaction. So how satisfied are you with your work? Your burnout risk, how likely are you experiencing burnout at this point in time? And your secondary traumatic stress. So how likely are you experiencing secondary traumatization at this time? This is the actual instrument, and Rana will mail this out to you in a form that you can fill out. So you can see it's just 30 questions, and you score it on a scale of 1 through 5, and then it gives you instructions on how to score it for yourself. And this can be really helpful, say in the last 30 days, in this just last month, where am I on this instrument? And this can help you with that first step, identifying what's my risk, right? And where am I? So that way I know what interventions I need to focus on. Also, as an individual, I think it's important as part of our strategy is to adopt an active mindset around coping. This is both prevention and treatment as an individual. The root of the word coping is a French word, and it actually means to meet in battle. And I love that because it really highlights that this is an active process. We don't cope passively. And in fact, if we're not taking active, purposeful steps in our daily life to cope with the stress and the systems barriers and limitations and the acuity of the patient population we're serving, then we are going to be at risk, right? So making conscious effort to solve those problems when they're solvable, and seeking to master, minimize, and tolerate stress in an effective manner. So not letting it accumulate, not letting it build up. Professionals who really adopt this active stance of coping, both with their own stress, will impact their colleagues, and they will impact their traumatized patients because they will have that energy put into place. This is something that I have to intentionally do. So what are some of the things that you can do intentionally? Well, there's a number of things that we can do to take care of ourselves, right? Prioritizing personal time, close relationships, all this stuff, maintaining a healthy lifestyle, fostering recreation and hobbies, practicing things like mindfulness and meditation and spiritual development. But that's all kind of like the big picture, vague stuff. What are some of the less common things that we talk about? Number one is having an evidence-based practice. So the research is really clear. If we're delivering EVPs to our patient population, we're using the best practice standard for that intervention. we are going to be less likely to experience burnout because we're going to see improvement in the population we're working with. So EBPs very much predict lower levels of emotional exhaustion and help to buffer the impact of high caseloads and high traumatized or high acuity work. So thinking about like what you guys are all here for today, you're join this echo because you care about EBPs, because you care about having best practice standards and you want those tools in your toolkit. So continuing to do that is a huge protection for you. Making sure that you're moving towards mastery of that skills is another level, because when you have confidence in delivering that best practice, that is also positively correlated with decreases in emotional exhaustion. So thinking about that. Other things that you can do, or everyday prevention, is looking at having a coherent philosophy that guides your work. So what does that mean? That means consciously sitting down and mindfully thinking about your why. Why do you choose this work? How is what you do unique? Why is it meaningful to you? Carrying that outlook with you is really, really important to help you manage some of those inevitable disappointments, obstacles, stressors, barriers, that day-to-day kind of like annoyance that's always present. If you know, okay, I know my why, I can really quickly connect with that. And that helps me to keep that big picture, that 8,000-foot view. What am I doing in this system? What am I doing working with these patients? This is why I make a difference. So it's what is to give light must endure burning is a expression from Viktor Frankl, right? So we have to know why we've put ourselves in the fire, or we're not going to stay. We're not going to stick it out. So having that enduring philosophy and being able to connect with it. Another thing is shifting our focus to a problem framework from an overwhelmed, exaggerated framework. So when we're entering burnout or we're firmly in it, our work starts to feel like a chore. We're not excited. And we start to say lots of things like, I can't stand it. Oh, I hate it. I don't want to do it. And COVID has only exacerbated this, right? Our burnout rates are through the roof because of this past couple of years with COVID. So ask yourself, what can you do if you were going to give a quick elevator speech? What would be a way for you to flip that on your head, is to quickly turn anything that you're experiencing that has it's like a statement and that has a close-ended thought into a question. So think about a way that you can go from I just can't face another day to what can I do tomorrow that would make me feel better than I do right now, right? Turn it into a question so that it actually has a solution and a way out, even if it's just breaking it down into a bite-sized piece. Because one thing to recognize cognitively is what happens when we deal with a lot of chronic stress and a lot of difficulty as part of our ongoing work. We hold on to the pain that we experience, the emotion of that. We hold on to that psychological distress differently than we do the actual nuts and bolts. And so we have to recognize that pain is going to show up, that pain point is going to show up over and over again, and we need to turn it into something constructive and not get stuck with that pain, right? So placing your attention on the stressor and trying to focus, what can I actually shift? Would have, should, and how could I change that into a question? And that leads us away from that learned helplessness, that frustration, taking control of it and turning it into a problem that can be solved. So instead of my schedule is so stressful, it's not manageable, say, what can I do to make my schedule manageable? Instead of I have so much work, I'm never going to see all of these patients, say, what can I move to prioritize my work into manageable bites today? What can give? Right, so giving yourself permission to take a really proactive problem-solving stance with your day is important. And then lastly, thinking about how are you being intentional with regards to guardrails. So recognizing that mindfulness isn't something that we can do in a 30-minute meditation session, that it's something we have to adopt in a minute-to-minute basis. We really, when we're dealing with a high acuity population and lots of systemic issues, we really have to be mindful in our work routines on a pretty much minute-to-minute moment and think about where can these guardrails go up to make sure that I'm being purposeful with how I'm entering work and how I'm leaving work. So I think someone said that their daily commute is part of their stressor. How can you turn that into something where the guardrails actually shift to when I enter the door to my facility? So that whole commute time, what am I listening to a book on tape? Am I, doing some really interesting podcast, or am I talking to loved ones? Like, what am I doing with that time that's part of my personal life and feeds me and gives me joy, rather than having that just be a part of the workday, part of starting that piece. And then when I end work, where does that guardrail end, so that I have a really clear routine to maintain that? And that's important and very symbolic, and helps us to kind of keep that going. Even if you work from home or you're doing telehealth, thinking about how can I put guardrails on that time. When I sign on to Zoom, I'm in my work clothes, I'm in work mode. And as soon as I'm off of that, I'm in my personal time, and what signifies that shift. So really thinking about psychologically putting up those guardrails and making sure that in that free time, I'm being very mindful and conscientious to do the things that feed me, not wait for that to happen down the road. What do I need to do today? And what are the steps that I can take today to be present for my family connections, my social connections? I'm not going to tune out or turn off today. I'm not going to just be like, oh, it's too much stress, because that downtime is where you put the gas in the gas tank. And if you're not doing that, if you're not being thoughtful about those activities, you're not going to have the energy to carry you into the next day. And then the last thing to consider is a gratitude practice. And so psychologically, we found that gratitude is one of the most powerful things that we can practice as human beings. It really is associated with higher levels of contentment, happiness, hope, and this sense of meaningfulness. So even just being able to make a list, and I try to practice this as frequently as daily when I'm going to bed at night, thinking through, what can I be grateful for today? What can I celebrate? What was that one small thing that I felt proud of, that I accomplished, or that someone did for me? So just looking through that list in your mind on a daily basis, that helps to shift the focus from the problems that are going on and the things that can't be changed as easily to the things that you do really appreciate and value. So because gratitude serves to sustain people's sense of personal goodness while linking them to a moral horizon toward which they might strive, it accumulates in an individual's sense of interconnectedness and personal growth. And so thinking, where am I able to interject that gratitude, to say thank you, to say I appreciate this, to say I am glad to have this opportunity to sit across the room from this individual, even if they're truly suffering. I'm bearing witness to that, and that's something I can be appreciative for. So I'll end there.